Good evening, everybody. It's Dr. Radialis again from the Georgia office, sharing some ideas, thoughts, and tons of love. So today I would like to talk about what happens when the numbers don't add up. And what do I mean with that? I usually like to share some ideas based on, a case that I discussed or saw the few days or the week before. And I've seen a few situations where I have a 39-year-old or a 40-year-old with an AMH more than one. So I was discussing with a patient today. She's 39. I'll use her because it's easier to use a particular example. She's 39. AMH was 3, and everything looked normal. She had a history of a tubal ligation and then a tubal reversal that failed, and then she started doing IVF. Well, she had done one IVF, 2 IVFs total, and then the first IVF she got 15 eggs. And out of those 15 eggs, she got 5 embryos. And then that didn't work. And then the second round, and they were normal protocols. The second round, she had 12 eggs and only 3 day 3 embryos. And when we reviewed her chart, everybody had assumed that because she's 39 with an AMH of 3, she's normal, right? She's your average patient. We don't necessarily need to get overly aggressive with her in terms of priming or treating her like a low reserve patient. And that's inspired the title of today's talk. What happens, what to do when the numbers and the scenario doesn't add up. So in her case, this is what we did. I said, let's go for mini IVF. Because even though your numbers look good, and remember, your AMH, we grab it at a moment in time, but we don't know what her AMH was. What if her true baseline is 7, so 3 for her, it's kind of going down the slope of decreased ovarian reserve, right? So we look at this range and what's, low normal, average, and high normal. But the reality is that that's just a number. What works for your body? And that's information that can be gathered through the years, but we're not checking your AMH at 22, right? So, but she is behaving like a decreased ovarian reserve patient as I looked through everything. So she was behaving more like a 40-something-year-old rather than a 39-year-old with an AMH of 3. So we decreased the dose to go mini IVF. We're going to do priming. I added the Omnitrope human growth hormone, started on the low dose naltrexone before. She had not fully converted to the keto way. So we talked about going more keto-ish, meaning the grains. The grains are brutal for your endocrine system. So wheat, corn, soy, oats, rice has to go. Processed foods has to go. Sodas, of course, have to go. I'd rather you have potatoes than you have pasta. Those little things, every little thing starts adding up. And she's going to do ovarian PRP. And we decided she was debating whether to start IVF. She's going to go through another cycle next month. And I told her, look, let's just give it 2 months to get you ready. I put her on the triple antibiotic. She's had so many procedures that even though we give you short-term antibiotics, we always have to wonder about inflammation that predisposes you to subclinical infections. So I put her on the triple antibiotics to try to clear her flora, her gut. I'm going to see her next week. We're going to do an endoscratch and a PRP as well. So we're covering all bases, but first thing is we are treating her like her age and not the numbers. We're treating her like her clinical scenario and not her numbers. She had done genetic testing. That's another thing that we would have to look into. I mean, is there any genetic component that is presenting this way? In her case, the only thing that we found, because she had genetic testing, was that she was an MTHFR gene mutation carrier and she was already on folate. We did add different supplements because folate is part of the B complex family, and sometimes there's other cofactors that might be needed. So I make sure that she was fully covered with a good omega-3, a good complex B, gland therapy with the female endocrine pack. She's doing the molecular fertility prenatal or women's complete. And then do the priming for those 2 months before she started IVF. Same thing, another case that I see a lot is that everybody is terrified of the polycystic ovarian syndrome patients. And then they have an AMH of 8 and then they, sometimes the doses that we choose are low. With PCOS patients, again, when the numbers don't add up, is you have two groups. In my experience, you have the very sensitive, the ones that end up with the hyperstimulation syndrome, but those tend to respond very well to dose low clomid or letrozole. So they usually get pregnant with their regular OBGYN. And then you have the resistant PCOS, the ones that no matter what you do, they don't ovulate, no matter what the AMH is. And those tend to have more insulin resistance, so they do really good on the keto, okay? But the numbers don't add up, so you have to treat them like a regular patient. You have to go up on the doses and not go too low because of the way their bodies behave. So I wanted to bring those two cases up, the normal numbers but still behaving like a low reserve patient, and then the PCOS looking numbers that don't behave like the hypersensitive PCOS. All right. So let's see what questions you have for me today. 34-year-old, AMH of 4, do you suggest a mini IVF or IVF? I think that we are in general moving to mini IVF almost by default because patients tend to do better on slightly lower dose. So we have decreased a little bit where our starting point is. And hello, everybody that's joining me. Thank you for joining me and sharing your ideas. And also, if you have happy endings, happy success stories, please share them with us, because sharing the love and sharing the hope is what keeps us going. Okay. So it's 44 and blood tubes, IVF, good choice, or a mini. Older ladies tend to do better on mini IVF. Traditionally, mini IVF would be as low as 100 of Gonal-F and 10 of ACG or 75 of Menopur. Our new start is 220 of the ACG together with the letrozole, and it's giving us pretty good results on those borderline patients. Is AMH of 1.4 good for a 22-year-old? No. Is that a good number for IUI? Does adenomyosis cause uterine lining not to grow while ovulating? If you have adenomyosis, yes, that could be an issue. There are ways around it. I would suggest keto diet, huge, doing uterine priming. And what does that mean? That means doing acupuncture, doing fertility massage before trying to, taking a break and trying to get your body in a better place. Get on the right supplements. I have supplements for uterus specifically, and then the endocrine pack, and then these and that. doing an endoscratch and a PRP to stimulate that lining, kind of clean it up, even considering doing the triple antibiotics with probiotics, again, as a way of trying to clear the bad guys and repopulate with the right people, the right guys. Okay. AMH of 1.4 in that range that I was describing is considered low normal. For a 22-year-old, it's low, but you should be able to, if your tubes are open, and 1.4, we're going to be able to ovulate or help you ovulate, and we clear your uterus, you should be successful. Semen normal should be successful. Did you recommend birth control for a few weeks for a woman with low ovarian reserve? In general, I do not place patients with low reserve on birth control pill. Every case is different. There's scenarios where it's necessary. We sometimes will put people on estrogen alone or estrogen with low dose progesterone, which is different for birth control, especially when they have the baseline numbers are not so great and we need to bring down the FSH and the LH. We'll do that. Yes. So I see that a lot. I see a lot of patients that did not have fertility issues younger, but just remember, you feel the same, you are the same, but this vessel that we are moving around in this human world loses biological reserve. So your body will change. So you cannot compare yourself when you were 25 or 30 to when you're 40. It's a different person completely. And I know it's a shocker for a lot of patients because they had no issues prior to their tubal. But it's even something as simple as a vitamin deficiency from wear and tear. Your body needs a lot more to heal. You live longer, so then your levels, like I said, your vitamin levels, your mineral levels have been used up through the years, and you don't replenish fast enough. There's so many factors. So it's a very common scenario that you're assuming that because you did not have any problems, you're going to get pregnant, and it doesn't work that way. All right. But there is light at the end of the tunnel. Okay. I'm just sharing because sometimes you need to hear it from like a different perspective, and it kind of goes, and then you have that moment, and then you can refocus and maybe do the things that you need to do to get to the goal. Okay. The prize is the pregnancy. The goal is getting pregnant. The way you're going to get there, it depends on what path God has for you. Have you experienced difficulty with people with celiac having less success than someone without? I was 24 when diagnosed, and I take gluten-free diet now, but I didn't know. So celiac disease is an autoimmune disorder. Okay, it causes inflammation in the pelvis, especially if there's any cross reactivity with other grains and wheat. So for you, like a very strict keto diet could be a life changer. And then, but we are successful. We're very, very strong about immune protocols and handling the immune system. Those of you that have been with us for a while know that Dr. Kids is huge about reproductive immunology. So yes, we have patients like you, or even worse, with like multiple autoimmune inflammatory situations, and we'll push that envelope for you. So IVF in Atlanta, I know it's a hot topic. We are working towards that. There's a lot of steps that need to happen. Transfers will probably happen first. So frozen embryo transfers, that the embryos could be shipped down already made. The original time frame was somewhere between March and June. I don't think March is going to happen because we're not even building yet. So probably closer to the end of spring and early summer if things continue to evolve. But it is in the pipeline. We're hoping to have it for you in 2021. There were some delays due to COVID, but we're back on track. And I personally have declared 2021 to be my year. So I share that with you. Claim it to be yours. So 2021 is going to be a year full of adventures and victories. With a fresh transfer, why don't we leave a follicle to make corpus luteum to help with progesterone? With a fresh transfer, you will have some of the puncture sites will have a create some sort of corpus luteum. So and remember, a fresh transfer is right after retrieval. So you can't have the embryos unless we take out the eggs. So some of them will degrade completely, but I'm sure that if you had a lot of eggs, one of them might end up creating a mini corpus luteum. Taking your line of thought, that's why I really like letrozole transfers. Meaning on the next month, it is a frozen embryo transfer, but it's an ovulatory cycle, either with letrozole or natural. So you do have a corpus luteum, a real ovulatory corpus luteum that that will help with progesterone, and that sometimes really helps women that don't do so good with the progesterone injections, and all of the other ways of getting progesterone, because then they're creating some of their own, so they don't need as much exogenous progesterone into their bodies. Okay, what are the tests before doing IVF? So a lot of clinics will do extensive testing on the males. We do recommend genetic testing on both partners. And for the boys at CNY, we just need a semen analysis. I know that in other clinics, they have all the testing that the girls do in terms of hormones and STDs and stuff but for CNY, semen analysis and then the genetic testing, which is optional. Hello from Ohio. Hello from anywhere and everywhere. The world is becoming smaller with so much technology. So that's kind of cool. How long after ovarian PRP it is best to have an egg retrieval? So in the PRP world, and I've been in the PRP world for over 10 years. I started through cosmetics, then sexual dysfunction. I mean, I've injected PRP in very weird places in the body. In the PRP world, they say it takes about 3 weeks to get maximum result from an injection, whether it's the shoulder or the ovary. Because what it is we are harvesting your natural healing proteins from your blood and then concentrating them and put them where we want to cause that accelerated healing. So putting them there, you have to give it time to work. So I would say the fastest would be the following month. Transferring a day 3 frozen embryo, which protocol would you provide? The default protocol right now, it's a medicated cycle. So as soon as you get your period, you go for a baseline ultrasound and blood work, and you start estrogen, usually by mouth and occasionally vaginally, depending on how your lining responds. And once you get to the right place and your lining is trilaminar and more than 7 millimeters, then we convert to progesterone. For day 3, you would have 3 days of progesterone. For a blastocyst, so 5 days and beyond, it'll be 5 days. That's kind of the default protocol. You can also do a natural cycle with trigger or a letrozole cycle with trigger. What does that mean? So a medicated cycle is not ovulatory. This cycles you will ovulate. So we follow the egg and the lining and bring it and then provoke ovulation when the time is right. And then 36 hours after trigger, that's your day 0, you start the progesterone. Okay. I'm 33, PCOS, AMH of 1.6, priming with CoQ10, LDN, and Serovital. Yes, there's a few more things that you could add. PCOS with an AMH of 1.66 is questionable. But again, we don't know what your baseline was at 23. And definitely priming is going to help you. I would encourage a female endocrine pack, and that you can get at the Atlanta office. I'll give the number to the Wellness Center, which is 770-266-0933. And the Atlanta office is 770-266-3930. That is the clinic side. I know that sometimes there's challenges with getting through the lines. I don't know where the glitch is. You are welcome to look me up. My name is Maribel Verdiales, and I have a Facebook page. You can send me a quick message saying I need to talk to the Atlanta staff, I can't get through, and send me your information, your phone number, your date of birth, and I'll pass it on to the staff. So instead of you calling them, they'll call you. Also our financial person, she always helps out with this stuff. She'll kill me one of these days. It's J Perez at cnyfertility.com. So I'm just giving you choices of how to connect with us, because I know sometimes it can be challenging. 32-year-old PCOS, plus cysts in each ovary. Clomid did not work for me, and I'm letrozole 2.5 first round. Yes, you are what I'm discussing. So you're one of those cases that I was discussing that, people look the diagnosis of PCOS and they go very gentle, because yes, there's a group of PCOS patients that just will hyperstimulate with very little. After I have somebody that did not ovulate on Clomid, I don't use letrozole 2.5 because I know it's a joke. You need to hit them hard. So I usually go 7.5 or 10 on the first round. I'm going more 10 these days. And you have to make sure it's ovulatory, right? So I hope that you're getting a day 21 progesterone to check. I don't have regular periods, so I plan to get an ultrasound Thursday and see if I can start my period for retrieval. Or do I have to induce a period? You don't have to induce a period. If you go for a baseline, we can check. If your numbers are really good, we can give you medicine, whether birth control or estrogen to manipulate them, or you can have a withdrawal bleed with progesterone. So it has to be kind of what your age is, what those labs look like, and whether we either make you have a period or manipulate it such that we have a true baseline with low FSH, low estrogen, and low LH. My AMH went up from 2.7 to 3.97 last week. I'm 42B43. How did that happen? Because your body changes. So, we always assume it's going to change for the worse. Hey, our bodies are designed to heal themselves if you give them what they need. So something you've done, some changes in your lifestyle, supplements, there's something you've done that has allowed your ovaries to regain some of their function. So congratulations. I'm beginning to trying for a second. We did endometriosis surgery and IUI on my first. I haven't heard of AMH. What is that? It's anti-Mullerian hormone. It is one of the markers that fertility doctors use to see how are you going to respond to stimulation and potentially how many eggs. So it's one of the markers for ovarian reserve. An AMH of 1 and above is considered normal, even though it's really like low normal. Your average AMH for a young woman, it's somewhere around 5. So a 22, 23-year-old is going to be somewhere between 3 and 5. Above 8 is kind of PCOS-ish, and less than 1 is considered decreased ovarian reserve. 1 and above is considered normal, even though it's really like low normal. Your average AMH for a young woman, it's somewhere around 5. So a 22, 23-year-old is going to be somewhere between 3 and 5. Above 8 is kind of PCOS-ish, and less than 1 is considered decreased ovarian reserve. What kind of tests are done at baseline? I'm trying to get it done locally. So baseline would be a GYN ultrasound, a transvaginal ultrasound to check on the follicles. We check for estrogen, progesterone, thyroid, so TSH, LH, FSH, and the pregnancy test. So that's baseline. Also, is it required to go through testing again, or could we jump back to IUI? It's been 5 years. We like to see testing within a year. So if you have not had any testing in the last 5 years, things do change, like I was saying, and we would really prefer to have some stuff redone. Okay. What is a consultation like at CNY? Consultations have changed a little bit in the last year. We used to see a lot more patients in-house. Right now, we're not seeing as many. So for the most part, you will get on the phone with a provider, either a nurse practitioner, PA, or a physician, and they will go through your medical record. If there's any history, they'll go through your medical history, your surgical history, your gynecological, obstetrical history, and then see what you need, and how much more testing is needed. Some people come from other fertility clinics and they already had all the testing and were ready to go. And some people need the workup, so the hormonal panel, the STDs panel, the blood count, liver, kidney, some basic genetic testing, the dye test or the hysterosalpingogram, and the saline ultrasound. And I get asked why both. The saline ultrasound, it's kind of dynamic. You can really see the cavity. You blow it up with saline and you make sure there's no polyp distortions or fibroids in there, any adhesions. You will see the muscle as well. So it's kind of having a baseline, an enhanced baseline to some degree. A lot of times you can see the fluid flow through the tubes, but the gold standard to see tubal patency is the dye test, which is just an X-ray. It's a 2D X-ray, but you can really see whether there's spillage or not. In most CNY clinics, it's done at the same time. I know that we haven't quite started doing SSG at the Atlanta office, but that's going to be happening very quickly. Okay. Do you take Neupogen during stim or transfer? Today's my first day. Both. We've done it both. We've done Neupogen for stim and Neupogen for transfer. It is a immunological medication. Will Atlanta be open by next January for embryo transfers? I hope so. I mean, we're really trying to have it done within this year, hopefully by the summer. I am 3 days before retrieval. When am I supposed to do my trigger shot? I have an appointment tomorrow, but no one has mentioned the trigger shot yet. So the trigger has to be done 35 hours before retrieval. So if you have an appointment tomorrow, they're going to give you the instructions for that. You have a follicle of 18 millimeters developing naturally. So that is normal. I mean, yes, you can have a small cyst, but follicles are around, mature follicles are around that size. Okay. Hello, everybody. Hello. So what do I recommend for someone with low ovarian reserve? I recommend the kitchen sink. So diet. We are what we eat. So you need to get off processed food, sodas, alcohol, grains, wheat, corn, soy, oats, rice, go into a more low carb diet. And believe it or not, fat is where it's at. Okay. I know that for the last 50 years, the world has been fat free and low fat, and we're just bigger and bigger. And the reason is that the satiety center in your brain is fat mediated. If you don't eat fat in your diet, you'll never be full. So when you go keto, you actually get less and less hungry. So it's crazy, but that's how it works. I mean, fat is the most efficient fuel for the body and the brain. Half of your brain is fat. It took me a while, a few years ago, to kind of grasp that concept. But the more I read and the more science that I got to know, I saw the light. Then what else? So we talked about the diet, priming, PRP, platelet-rich plasma, every 3 to 4 weeks. The supplements, and so like I was saying, molecular fertility, the woman's essentials, the ovarian bloom that has CoQ10 and inositol, the female endocrine pack that you can get from the Atlanta office, CoQ10 if you're doing it separately. You can add CBD oil, a good source of vitamin E. I sometimes use Cataplex E. It's from Standard Process. That's one of the brands that I use. Or I could use wheat germ oil. You want to make sure it's food-based. There's other companies out there that will make food-based products and are really, really good. Human growth hormone, low-dose naltrexone. Depending on the scenario, possible antibiotic therapy. Wow, I think that's pretty much it for now. Okay. All right, you have a lot of questions today. That's awesome. So I'll just take a few more because time's kind of up. Baby does for everybody. I agree. DHEA, it is controversial. My background is on holistic medicine and hormone replacement. So DHEA is a testosterone. The reason that it works for ovarian reserve is because most women after 40 will have a decrease of all overall testosterones. I would test your DHEA before you start supplementing, because if you are normal and you go off the chart, not only is bad for your eggs, but you're going to start having male stuff, losing hair, getting like facial hair and acne. Okay. Let's see. Okay. All right, everybody. I know that you're full of questions, and I appreciate so much that you've joined me tonight. I appreciate all of you. Next Tuesday around 9, I know I was a few minutes late today, but around 9, we'll have another great discussion. If you have something that you want to share or you want to talk to me, again, you can look me up and send me a messenger or write to Jenny, or call the office 770-266-3930. That's the Atlanta number. May you all be extremely blessed. Like I said earlier, I have embraced and declared that 2021 is my year. So go ahead and do it with me. This is your year. The universe balances itself out, yin yang, black, white, and definitely 2020 was, kind of on this side. So 2021 has to be amazing. So have a great rest of your week. I will see the ones that follow the Spanish Facebook Live tomorrow around the same time. So 9 p.m. for Spanish on Wednesdays, and Tuesday, 9 p.m. in English. So bye-bye. Have a great rest of your week.